So thanks again for joining us today for this webinar on the theme of institutionalizing tobacco-free policies. My name is Jim Pavlik, and I'm the Program and Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus. In my capacity here at BHWP, most of my work is in assisting organizations to adapt their workflows for a variety of clinic quality improvement initiatives, mostly focusing on chronic disease prevention and control, with a particular emphasis in tobacco cessation interventions. Today's learning objective is to highlight the proven actions you can take to entrench tobacco-free policies into your organization's habits. And to do that, I'll have to explore the difficulty of change more broadly in order to understand why the proposed actions are effective, briefly review some concepts from the second webinar in this series, and discuss concepts in the design, implementation, and enforcement of tobacco-free policies that are critical to sustaining policy change over the long haul. So before going on, now that I've said this second bullet point here, I want to say that I will be bringing up the second webinar in this series a few more times. The low burden cessation strategies shared there and the best practices shared today are related topics. You definitely do not need to have attended that webinar to understand, appreciate, or use what will be shared today. If you attended that webinar, welcome back. If you missed it and you're interested, you can find a recording of that webinar on our YouTube channel. Change is hard is a truism that hardly demands deep reflection. We have all attempted a behavioral change and failed, and we've seen others do it countless times. Entire industries are built around the recognition that change is hard and in offering tips and tricks on how to make it easier. One critical component of the difficulty of change that I think is often overlooked is that the directionality of that change, whether it's for the best or for the worst, is largely irrelevant. In the second webinar in this series, I shared the story of a community behavioral health crisis center that was given the option of allowing tobacco use on site after having spent a few years as a tobacco-free site. They eventually refused that offer because to allow tobacco use where none was currently permitted would have been harder than dealing with client expectations and infractions. In this case, the status quo was already being tobacco-free, and any direction away from that status quo was the difficult choice. The fact is that organizations are subject to the laws of nature like any other object. And unless acted upon, the tendency is to continue tomorrow as you did today. When we think of clinical quality improvements, changes with the intention of making organizations perform quote unquote better, we often forget that whatever the organization is currently doing didn't just arrive out of nowhere. Every action, every policy was the result of a choice, a reaction to the needs of the client population or some regulatory demand. The organization as it is a creature of an evolutionary process. So any new change has to have as firm a rationale as all the previous changes. This isn't impossible, but we do have to make that case. And even if we do make the case, and even if it is accepted, we will, as agents of change, also have to convince everyone else that the change we propose is possible. Now, I didn't invent applying the 5 stages of grief model to the process of organizational change. I actually normally find conceptualizing organizations as individuals to be more problematic than it's worth. But this concept is pretty widespread among those who do this work professionally, and in this case, I think making the analogy is helpful. But in part, I think the reason this model is helpful is because in the way it is normally used in this domain is actually wrong. In the standard Kubler-Ross model, the 5 stages of grief, we have denial, anger, bargaining, depression, and finally acceptance, as shown here. The way organizational change professionals reconceptualize it replaces denial with doubt and anger with frustration. I think that's mostly right. Where I think they go wrong is they change bargaining to experimentation and move it so that it's after depression. They did this, I think, to preserve the 5 in the 5 stages of grief phrasing, and they did it to capture a really important difference between the 2 applications of the model. But I would propose that, in fact, the bargaining phase remains very much present. So I would keep it in, as pictured here. When I train organizations on why and how to design and execute a tobacco-free policy, most of what I deal with live is bargaining. And most of what they're going to deal with during the process of designing their policy is bargaining. Staff in particular will seek ways to extend the timeline To delay the day they go fully tobacco-free, they will look for ways to carve out smoking areas on site. They will look for ways that their department or their division or the patients they treat can be exempted, etc. And I believe that most of these attempts to delay or restrict the scale of the policy come from a genuinely good place, a sense of real concern. I think that some people truly believe that smaller policies or using a staged approach will be more successful. As I will argue later, the literature and our experiences at BHWP do not support these views. So what happens is organizations do go through this bargaining phase, and then the organization, or at least some people within it, will enter depression, which we might also call resignation, or better yet, acceptance phase 1. In the first phase of acceptance, it becomes clear this policy will go into effect. And so bargaining to delay, derail, or restrict the policy turns into experimentation, a good faith effort to make a policy that works for that system. And just to finish our now 6 stages of grief model, once the policy has been modified to fit the unique needs of the staff and clients, we move into the final phase, which is here called integration, but what I might call acceptance phase 2, or even institutionalization. This alteration of the standard Kubler-Ross change curve, as it has been used in the organizational change domain, is critical. Doubt, frustration, and depression are inevitable. Change is hard. Our goal is to turn bargaining into experimentation. So I want to take a look at them in a little bit more depth just to see if the differences between these two otherwise similar phases offers us some clue as to how we can make that transformation happen. As I mentioned earlier, it's entirely possible that efforts to stall a policy's deadline or scale down its scope could be driven by a good faith effort to make sure whatever policy is adopted is achievable. Regardless of the intent of these bargains, the effect is often to reduce the effectiveness of the policy, to halt its progress, and potentially to unwind it entirely. As mentioned in the second webinar, if an intervention fails to achieve its goals, it's unsustainable. As we'll discuss going forward, the most successful policies are the most comprehensive ones. Scaling down reduces efficacy and therefore reduces the chances that the policy will last. By contrast, experimentation is not about reducing the ambition or altering the goal of a policy, but rather in making sure that its nature is appropriate for the organization in which it's deployed. That is, experimentation isn't about whether you will have a tobacco-free grounds, but how you will achieve that goal. In other words, the trick of moving from bargaining to experimentation is to make a convincing case that the change is inevitable and possible. This will lead some staff into depression. This is an unavoidable aspect of change, but not just unavoidable, but necessary and ultimately productive. With that in mind, some of this material was covered in the second webinar, although we didn't discuss it in precisely these same terms. With this new framework now made explicit, let's review the general approach to sustainability used in the second webinar. Pictured here are the logos we use in our tobacco-free policy toolkit. A wonderful resource that I think you will find useful whether you're building a tobacco-free policy from scratch or revising and updating an existing one. Each of the concepts discussed today are given a deeper treatment with citations in that toolkit. It also has several worksheets and other tools you can use during your planning or revising process. So it's definitely worth checking out if you are involved at all in creating a tobacco-free policy. Because some of the concepts in this slide were discussed in the second webinar, I will keep the discussion of them here brief. You can watch that webinar or refer to the toolkit for a deeper discussion of them. On the other hand, since the emphasis today is slightly different, it is worth mentioning them again. The first step in developing a tobacco-free policy that is more likely to remain intact in the long run is to establish a wellness committee. A properly organized wellness committee will have broad representation from different service lines and administrative offices, and even potentially from clients. A diverse wellness committee can provide staff the confidence that the final policy will be well designed and can convince them in advance that it will have the support it needs to be enforced. The process of designing and launching the policy should demonstrate the care and deliberation of the wellness committee. There should be multiple opportunities for clients to see, reflect upon, and respond to the policy content and its timeline. This type of transparency and openness to review reflects the pride that leadership and the committee has in the goal and demonstrates the confidence to withstand criticism. Both in the delivery of services and in enforcement of the policy, your agency should consider itself as a member of a broader community working together to address this country's single largest cause of death. In the delivery of services, it is potentially a site to which others are referred. And it's also an organization that can refer clients to cessation services that they don't offer. During the planning process and enforcement periods, the organization should also reach out to immediate neighbors to solicit their input and elicit their support. Finally, we underscored the importance of collecting data on the policy in order to ensure that it was having the desired effect and adjusting it as new realities impact success. Today's conversation begins where that conversation ended. That conversation's focus was that in summary, if we make sure that the administrative burden and the actual financial costs are low enough, then new additions to the workflow are more likely to persist. Today, we are looking at those administrative and policy choices we can make that will reduce resistance in a psychosocial sense, and perhaps even help create and sustain vocal champions. And we're going to begin with the most crucial element, communication. The Wellness Committee should begin thinking of a general communication strategy at the same time they begin thinking about their overall timeline for developing and rolling out the policy. One thing I hope you take away from today's presentation is that a tobacco-free policy may be hard to do, it may take time, it may even have some costs associated with it, but ultimately, it's the right thing to do. It's a major service for clients, and it provides a lot of new opportunities for staff too. Organizations should be proud of the work they're doing. A mistake a lot of organizations make is that they blame the change on quote unquote them, the state, a regulatory agency, an accrediting organization, etc. Or some leadership will know that the move is the right one, but they so fear the backlash that they try to design the whole plan in secret and then spring it on the staff over a relatively short timeline. Both of these convey that there's something wrong with the policy or its goals, that it's shameful in some way. So in addition to communicating important basics of the policy, like the timeline and its content, you want to accomplish three other things with your communications efforts. You need to make the case that the policy is internally driven and derives naturally from your organization's core values, including its commitment to providing the best care to all its clients. You also want to make sure that the Wellness Committee, or whoever is designing the policy, is open to feedback throughout the process. And I cannot stress this final bullet point enough. You have to signal the organization's and its leaders' commitment to the policy. In some studies on this issue, the single most critical predictor of success is whether the person or people in charge are committed to carrying this policy to completion and supporting it afterward. If the leadership is committed to success, then they will succeed. If they aren't, then any excuse to give in to inertia will be good enough. So on the one hand, having a commitment to the cause is critical, but also communicating that commitment as well. Finally, be sure to use a variety of voices throughout your communication strategy. Utilize administrator and staff at varying levels and across departments. Use clients and their families. Highlight community members and appeal to experts. No individual voice is persuasive to all people. So getting to the best way to make sure the best way to ensure that you make the most persuasive case is to use a lot of different voices. Now we move on to another critical element in determining success, and that is staff support and buy-in. There is a mistake we all make as people. We often assume that if only people we were trying to persuade just knew the same things as we did, then they would see things our way. If only our coworkers knew 500,000 people died every year from tobacco use. If only they knew that half of all people in substance abuse treatment would die from tobacco use and not the drug they were receiving treatment for. If only they knew that those who receive treatment for their nicotine dependence at the same time as they receive treatment for other substances were 25% more likely to remain abstinent from both, then they would just agree that a tobacco-free policy is the best thing we can do for our clients. But there's a lot of good research that this is not the way we make decisions and come to conclusions. One interesting thing about tobacco-free policies are the implicit ways our own behaviors and knowledge work unconsciously to determine our positions. One thing I should make clear before I discuss this slide here is that a tobacco-free policy is not a prohibition on the behavior in general. Staff can use tobacco. Clients can use tobacco. They just can't do so in a way that implies that the organization supports the activity or exposes others to the associated risks of nearby use. In other words, you just can't use it on site or possibly during your shift. But it is true that when we measure various attitudes and opinions associated with tobacco-free policies, staff who smoke are less likely than their abstaining peers to see the positive impacts of the policy and more likely to see problems, including misdiagnosing withdrawal and having a more pessimistic view of client self-efficacy. So one course of action here is that we want to support staff's own quit attempts. As a whole, anywhere between 65 and 75% of all tobacco users currently want to make a quit attempt in the coming year. And between 60 and 65% of them will go through at least one 24-hour period of abstaining as part of a quit attempt. A successful tobacco-free policy incorporates a parallel process, encouraging and supporting staff quit attempts. At the same time, it encourages and supports client quit attempts. Every ex-tobacco user is not only one more person whose attitudes move from resistance to support, but they also become potential future champions. So let me restate that. A policy that simply governs which tobacco products are prohibited from being used and where that prohibited zone is a tobacco-free policy. Such a policy doesn't need to concern itself with the tobacco use status of those who enter the zone of prohibition. However, as a matter of sustainability, and as you are those who are tasked with enforcing the policy, then it is in your best interest to support this policy in a way that drives down violations. And I'll say this again later, people who do not use tobacco are 100% more likely to not violate a tobacco-free policy. So the more non-tobacco users we can make, the more effective and sustainable our policy becomes. So while we cannot and do not treat a tobacco-free policy as a ban per se, we do want to acknowledge that such a policy can be used to inspire and support quit attempts. And rather than just tacitly acknowledging that fact, we should lean into it and try to leverage it for the better health and wellness of our staff, our clients, and their friends and family. Another and far more actionable source of resistance is that staff simply do not feel confident in their ability to address tobacco use. They feel like they don't have the skills necessary and may even feel that in engaging clients on this issue, they expose their client to potential harm. Support for tobacco-free policies among staff rise after skill-based training. So I want to reiterate that as well. Staff education is part of training, but that's not the part that actually changes their minds. The element of a training that has the most impact on attitudes is the part that expands their skill set to include tobacco dependence treatment. Whenever I train organizations on this process, I often say that at some point there are ways in which drafting a policy is very hard and other ways in which it's very easy. The very easy part is the literal drafting of the policy. You can go online, find a model draft policy, do a find and replace, changing the name of the organization to your own organization, and voila, you have a policy. The hard part is all the staff and leadership buy-ins, the stuff that we've been talking about. But even during the drafting phase, there are two elements of the policy content itself that deserve to be called out. And that is how comprehensive and how complete it is. A successful policy has no exemptions for any product and not for anyone that visits or works on the grounds. The fact is that stricter policies make more sense from a philosophical point of view, and the lines of infractions are much starker and therefore much easier to enforce. To draw that out a little bit more, if the rationale that drives the policy is that, quote, tobacco use is harmful, it's hard to defend the implication of smoking shelters on site, which seems to imply something like smoking that you do on the edge of the property is less harmful. Focusing on ideological consistency seems like pedantry, but in fact, such inconsistencies often resonate very deeply with people and can be brought up as a point of weakness to be exploited by those initially opposed to the policy in general. This implication extends not just to what we would call a partial ban, where use is allowed in specific locations permanently, but also during so-called staged approaches. Many organizations make a plan to go entirely tobacco-free in, say, 2 years, but in the meantime, allow tobacco use in certain areas on the property. This leads to the purchase of signs that say, smoking permitted in this area only. And sometimes it leads to the construction of permanent buildings, shelters, benches, or other types of shelters. Those structures will not have fully depreciated in the 2-year timeline originally proposed, and so the tendency is to just continue to let them stay. I'm not going to say much on the launching of the policy. In a sort of simplistic fashion, the policy is launched on the day it goes into effect. On one day, people who are observed using tobacco on site face no repercussions, and the next day they do. That's launching. Some things you can do, there are some things you can do to make the launch easier, better, and more momentous are listed on this slide. You can have a practice day. You would normally sponsor the practice day a month or so before the policy officially launches. This allows client and staff to test new daily routines and get a feel for what works and what doesn't. This provides time to make adjustments to those routines and perhaps to the policy itself. It's also an opportunity to observe that the place won't burn down on the actual launch day. Begin practicing enforcement prior to the official launch day. Approach tobacco users and remind them of the approaching deadline. Engage them in mindfulness regarding their plans after the policy goes into effect, asking them when and where they're going to use tobacco so they aren't doing it on site. Are they going to try and quit? Do they know about the cessation services and supports you or your community partners offer? Do they know how to contact the quit line? If they're staff, are they aware of the organizational insurance plans or the EAP's benefit and how to access them, etc.? Finally, on the actual launch day, it's a good idea to use it as an opportunity to celebrate the achievement and this new era of whole person care. As I said during the communications portion, the organization should always be celebrating this move. So now we're going to turn toward enforcement. This is the area that causes the most anxiety and concern. This is the area that everyone is reluctant to do and depends on everyone else to do on their behalf. The problem is that if everyone is depending on everyone else, then no one enforces it, and suddenly you only have a policy in name only, a reality that some of you may be facing already. So the first thing I want to point out is that if you follow the advice in this webinar or done the exercises in our policy toolkit, then this won't be as bad as you think it will be. The fact is that 20 or 30 years ago, people using tobacco on site may have balked at or challenged the enforcement of such policies. But psychiatric facilities and other behavioral health organizations began going smoke-free in the 1980s. Hospitals followed suit shortly thereafter, and for the most part, people get it. They may not like it, but they get it. If the policy and its launch day have been widely promulgated, then a lot of the early infractions won't come from active resistors challenging authority, but from people who just forgot. A gentle, respectful reminder is normally all it will take to get them in line. That's not to imply that it's not to deny that there are problem users who just want to defy authority. But generally speaking, the reason that enforcement seems hard at first is because people don't like being confrontational. But what goes for the staff as it regards enforcing the policy, so it is for users violating it. Most people don't like confrontation, and the enforcer, that is, has this advantage in most interactions. And to the extent there is active resistance at the beginning, over time, if enforcement is consistently and fairly applied, the need for enforcement goes down. That said, there are some things you can do to make sure that enforcement happens, that it happens in the right way, and effectively drives down violations to a manageable level. The first thing you can do is develop scripts. One of the requests for assistance I turn down pretty frequently is to create enforcement scripts. In my opinion, this ends up being wasted effort on BHWP's part. Scripts really need to be tailored for the specific environment where they are to be deployed, using specific language that makes sense within that organization and also that geographical or cultural population. So here's what I suggest. The Wellness Committee should convene and call as support other key staff leaders, supervisors, managers, and directors. These individuals should identify likely places where violations may occur and prioritize those that pose unique challenges. For example, in their own cars in the parking lots. During this process, they can identify both classes of potential violators, for example, family members of clients, but also specific individuals, those who have been vocal about their negative opinion of the policy, clients that regularly use in large amounts. Together, they should work out short, respectful ways of addressing that person using language familiar to the enforcers. That is, pulled from the organization's value statements and or from the policy itself. And then have that group role play these interactions, improving or improvising their responses to challenges. That improvisation, that's where the enforcer puts the policy in language that resonates with them, is where the real confidence to actually enforce comes from. It's during this exercise where staff may start to generate ideas for enforcement aids that make sense to them. For example, a staff member during a role-play encounter might say something like, I'd feel better if I didn't feel like I was just marching up to them to give a command. I wish I had something to offer them. So one organization that BHWP worked with in the past made business cards with big smiley faces on one side, and they had a piece of nicotine gum taped to the back, along with a sentence that read something like, we here at XYZ Inc. understand how hard it is to remain nicotine-free. Please respect our other clients while you're here. If you need additional support, please contact Human Resources at ... Be sure to talk to your immediate neighbors, your referral sources like hospitals and jails, and also the services that you refer to. Make sure they know about your tobacco-free policy and try to get their support. Again, the policy doesn't ban use outside the organization, but at the same time, the more quit attempts we can encourage, the better. Ex-users may become vocal champions for the cause, and non-users, as I already mentioned, are 100% more likely to not violate the policy. Making sure that users know they are embedded in a caring community fostering quit attempts can be a compelling factor, building confidence and driving those quit attempts. Your policy should have a disciplinary procedure written into it. It should be proportional to the type of infraction that using tobacco on site represents, and it should be in line with other similar policies, and it has to be followed through with. I want to emphasize that this is not normally an issue. People, employees in particular, follow rules even if they don't like them. And they certainly don't normally risk their jobs over these types of disagreements. At the same time, we need to understand that if someone gets an official verbal warning, or if they progress to a formal written warning, then we aren't disciplining them for smoking. We are disciplining them for violating an organizational policy. Again, it's important for all to agree with, defend, and support the policy. I would advise against using a "I didn't write this rule and I don't support it, but I have to write you up anyway" sort of tactic. It will help prevent future violations if the supervisor offers a full-throated defense of why the policy exists to start with. At the same time, employees who violate this organizational policy are likely to be violating others as well. How repeated infractions are carried out with clients, how discipline with clients who repeatedly infract the policy should also be aligned with how other behavioral infractions are responded with in other instances. If you're in a residential setting, for example, then whatever policies are already in place for searching for and confiscating contraband should just be extended to tobacco, nicotine, e-juice, and other paraphernalia. Using on-site should be responded to the same way that other violations are responded to. Trading, bartering, and selling for tobacco-related contraband should be handled the same way that transactional violations are handled with other products. Dress code violations. If you, for example, prohibit the wearing clothing that advertises alcohol brands, that policy should be extended to tobacco brands, etc. Basically, just align your tobacco policies with pre-existing policies. In all cases, be sure to remind those who violate that even if the user feels they are making a personal choice about themselves, their bodies, and their health, that in the context of a treatment site, their behavior is a trigger and an encouragement for others. Alcohol, like tobacco, is also legal in the world and not a drug of abuse for everyone currently receiving treatment for other drugs. Nevertheless, we don't abide, for example, members of our psychoed groups to sip on a beer during group. Also remember that about 25 to 30% of folks receiving treatment are never smokers or ex-smokers, and an additional 50% won't quit within the next year. So while the majority of folks at any given time, about 70% or so, are currently users, a significant number of those present are not users, and a significant majority of them would like to quit. Our smoke-free policy is for them too. Having a clear enforcement plan is a critical element of success. If I were to boil down the three most critical elements, it would be a firm commitment to succeed, the formation of a wellness committee, and enforcement support. So as I move into the wrap up, I want to leave you with some key takeaways that are partially synthesis of what I've said so far and partially just a summary. Complete bans governing all products, and those bans being equally applied to all persons, are much easier to explain and enforce. Moreover, they reinforce fairness and equality. Some organizations want to exempt certain divisions or certain types of patients, but this creates perverse incentives. For example, to malinger, to fake to be sick in order to move into wards with a more lenient tobacco use standard. The best approach is to go 100% tobacco-free in the shortest amount of time that allows for a good planning process, including soliciting feedback and revision from those impacted by the policy. This is normally no less than 6 months and no greater than 9 months long. The 9-month limit at the outer edge is a harder line than the 6 months limit on the shortness side. Some of you may have already spent years in a transition phase. You may already have everything in place. You've just been shy of setting a final launch date. In that case, you could probably go a little earlier. The fact is that change is hard and no one likes it. People hate the act of changing. So locking them into a prolonged transition period is the best way to get the least encouraging feedback. People would rather have the certainty of a policy they don't like than transition toward that policy. And some of you may be familiar with the work of Dan Ariel, a behavioral economist. When he was a college student, he was severely burnt over a large portion of his body. During treatment, the nuns who were his nurses had to regularly change his bandages. They would very carefully, very slowly remove them. He begged them to go faster because the pain was excruciating. They told him if he could prove that going faster was better, then they would go faster. So eventually he wrote a paper on it, proving that the level of pain from going faster was less than going slower. Now, despite the evidence, the nurses couldn't accept it. They continued to remove the bandages slowly. Don't be like those nurses. We have the evidence. People don't like slowly moving towards something they don't like. And also keep in mind that a lot of people, more than you might suspect, are looking forward to the new policy. They also hate this transition period. The best thing you can do to rapidly change attitudes about a tobacco-free policy is prove that it isn't as bad as people think it is. And the only way to prove it definitively is to go tobacco-free and show them. Predictions about the negative outcomes from the implementation of a tobacco-free policy are often exaggerated. In 75% of all tobacco-free transitions, aggression, discharge against medical advice, and use of as-needed medications all went down. And while 75% is a pretty encouraging number, it should be noted that in cases where the bans were absolute, this level of success was seen in 90% of cases. And in the 10% remainder of cases where the total ban did not work, its failure was a result of uneven enforcement and administration and not because of the unworkability of the policy itself. So the next few slides I added as a bonus. I was just going to flip through them if we didn't get here in time, but I have 10 more minutes before I want to open it up to Q&A. So we have time. So I'm going to go into it. In the second webinar, the main thrust, as I mentioned, was that if a service that would effectively help our clients had a low enough cost in terms of time, labor, or money, then of course we would do it. So the trick was to select evidence-based cessation services and arrange them in our workflows in the most efficient, cost-effective manner. The thrust was keeping costs low. There's another way to look at it, and that is whether or not a tobacco-free policy that encourages and supports quit attempts would save money. Do these sorts of interventions, in short, pay for themselves? The short answer is that they do. Now, I don't normally like to bring up the return on investment or the ROI angle for two reasons. One is the moral reason. As I mentioned in the second webinar, no one in behavioral health chooses to forego providing depression treatment or opioid dependence treatment because those treatments don't pay for themselves. The same should be true for nicotine dependence. Our clients use nicotine. They suffer increased morbidity and early mortality as a result, and it negatively impacts the maintenance of chronic mental health conditions, and it reduces the chances of recovery from other substances. we should be treating nicotine dependence even if it didn't pay for itself. The other reason is that to prove that these services pay for themselves in the long run takes a really deliberate approach by someone knowledgeable in such things, how to design the study, et cetera. Basically an economist or an MBA. A level of academic or technical know-how that most community behavioral health organizations simply don't have and would have to pay for, which would naturally cut into the ROI they're trying to measure. So we rely on the studies, and in study after study, this type of policy does pay for itself. So it's worth looking into where such savings come from. The organization itself often realizes some savings because it can renegotiate maintenance and custodial contracts. It can sometimes realize some savings from reduced insurance liability obligations. It can also renegotiate terms with its insurance plan. And since sickness and short and long-term disability due to illness are decreased, then associated costs are often reduced as well. Staff who give up tobacco use become healthier, which reduces their acute illnesses as well as their likelihood of hospitalizations. Staff become more productive and report more satisfaction with their job, even if they themselves do not give up tobacco use. It's been estimated that an employer saves or earns from each employee that gives up tobacco use nearly $6,000. Clients too see better health, which includes decreased acute illnesses, slower progression of chronic illnesses, fewer psychiatric symptoms, and general increases in quality of life. The interaction between tobacco use and other behavioral health conditions is important. By reducing this complication to care, it might be possible to move clients from an intensive case management situation to normal care. Depending on your reimbursement structure, it's possible that less intensive case management is a savings that accrues to both the client and the caregiving organization or the care manager. We often share that previous slide without going into too much detail about what, for example, staff productivity improvements really means. In that figure, there is certainly reduced absenteeism, but also reduced presenteeism. Presenteeism is when an employee shows up to work even though they are too sick to perform their normal ability. While we are all culprits of showing up to work when we should have stayed home, this scenario becomes more likely once paid sick days are used up, something that is a greater reality for both low-income workers who might not enjoy a paid sick leave benefit, and smokers more generally, who are often sick more frequently and more intensely, thus using up their sick days earlier in the year. But presenteeism also shows up as workers enter withdrawal during the day. While nicotine is a stimulant and known for its ability to increase attention and focus, this effect is primarily experienced by individuals who have not developed a tolerance. In individuals with a developed tolerance to nicotine, the drug only serves to regain baseline attention and focus, and that's the best case scenario. Nicotine is metabolized rapidly, and the negative effects of withdrawal are experienced within handfuls of minutes after the last puff. In the idealized 20 cigarette per day smoker shown on this chart, the smoker can barely stave off the negative effects of withdrawal even though they are able to smoke the entire day ad libitum. Withdrawal is experienced every time the jagged line dips below the smooth lower line. Now imagine the regular 9-to-5 employee who can only smoke 2 to 3 times per day plus lunch. Not only is the employer losing those smoke breaks in terms of productivity, but they're also losing the full potential of that employee who returns from each smoke break initially over nicotine from having smoked multiple cigarettes rapidly, and then who dives into a shallow withdrawal shortly after returning from the break, a state in which they spend most of their working day. And an important consideration at the client level for the client level savings comes in the form of not only less complicated treatment plans due to the exacerbating impact that tobacco use has on behavioral health conditions, but also as a secondary effect of the ability to use lower dosages of certain medications. This particular cost does not always accrue to the care organizations, but to the population at large if the care payer is a publicly funded institution like Medicare, Medicaid, TRICARE, or the VA. Of course, the benefit also accrues to the client. It's possible that the literal savings of lower doses will accrue to the treatment agency, but more likely the savings will show up again in the reduction in the amount of time and thought a provider might have to give a client with a less complicated, less interactive, less side effect riddled treatment plan. As always, check our website for other resources. I've already mentioned our tobacco-free policy toolkit. The toolkit I mentioned the most during the second webinar was the patient-centered tobacco cessation workflow for healthcare clinics. And while it does say healthcare clinics, I have frequently used the strategies and tools in that guide in other contexts, including behavioral health. And also to check out our partner sites, the Smoking Cessation Leadership Center and the National Behavioral Health Network for Tobacco and Cancer Control. They have webinars and all kinds of other toolkits and mini classes that you can go through. Just generally a lot of good resources there coming out throughout the year. And that just about does it for me. If you have any questions, you can, again, either chat them in or use the question and answer icon, the Q&A icon on the bottom to send us your questions, or raise your hand. And if I see your hand is raised, I'll unmute your line and you can ask your questions with your computer audio. Okay, seeing no questions coming in via chat and no hands raised, I'm going to go ahead and sign off and give everybody back about 15 minutes of their afternoon. Thank you all so much for joining us. If this is not your first webinar in the series, then like I said, welcome back. And if this is your first one and you enjoyed it, please check out our YouTube channel for the others.